Mitra, for your very kind words. And I hope the screen share is working fine.
Yes.
So we are meeting on the day when it is Guru Purnima. So a nice day to remember Sushruth, the father of surgery and cataract surgery on this day before we go on to this video. So this is a video which will be presenting my options and the technique, the options that you have when your rhexis gets broken in a radial fashion and you have a hard cataract in front of you. So it started with a very routine surgery in a mature hard cataract with topical anesthesia, temporal incision, and we are doing a staining because it is a white cataract. And then we proceed to do, it's a hard, totally nucleus grade 4 to 5 cataract. So we are starting with a relatively small rhexis, thinking of a possible raised intralenticular pressure and more cautious approach, small bites and small extensions of the rhexis gradually all around. So this is about 4 at this moment, 4.5. And by the time we reach the end, we decide that we can spiral it a little and we go on to increase it a little to about 4.5 to 5 millimeters. We are spiraling it and completing the rhexis. Now at this stage, we are reasonably satisfied with our rhexis and we do a hydrodissection through the main port with a small syringe with a backward pressure, but it seems that at this moment something happens. Sorry. So at that moment, the capsule has snapped. So this is the moment we are pushing in the fluid and the capsule snaps. So now we have to think of our options. We now have a hard cataract. We have an extension which has happened radially. Fortunately, it is not for my 6 o'clock. It is at horizontally, which gives me a little breather. And I feel reasonably confident that it is not extended backwards. I'll check with a little rotation. It is rotating well. So I think that if I proceed cautiously, I can possibly go ahead. And then I think of the options of doing a direct chop or doing a stop and chop. And then I decide that I would do a stop and chop and keep the forces of of breaking the nucleus away from the area of the break. So I begin with a little rotation to check that there is a good stability of the nucleus, and I decide to go ahead with the phacoemulsification by stop and chop technique. So all that I want to do now is to make a really deep trench so that when I separate the nucleus and break the posterior capsule, the posterior wall of the nucleus, that's the most risky part when I would use either centrifugal forces or increase the intralenticular pressure enough to cause the break to extend. So I go at multiple points, go to the full depth of the wound, and then do a separation of the nucleus. It is fairly hard and breaks with difficulty, but when I do it from multiple points, I have succeeded in separating it. The movement is good. I'm all the time checking for any signs of instability, a sideways shift or difficulty in rotation. And then as you see, my forces are being used on the right side with my phaco probe rather than I'm trying to minimize the force that I use for separation with my vertical chop on the left side where the break is. And here, as you can see, I'm lifting it forward. I'm going to emulsify the pieces in the iris plane. And I started debulking from the beginning rather than leaving the pieces in. I'm lifting off the pieces to debulk and reduce the intralenticular pressure. So once the first half is done, I'm proceeding with the rest, making sure that the chamber remains deep. My parameters are not too high, and I'm trying to not use any more forces. Now that it is debulked, the forces in the bag will reduce in any case. And I'm bringing all the pieces anteriorly and in the iris plane, I'm removing the fragments. So reduce the parameters further for the last piece and went ahead and removed this last piece as well. So we're so good, so far so good. You can see that things are okay. And then I do my IA, staying away from the broken rhexis area till the end. I'm used to coaxial, so I do my coaxial, even though the other option is equally good. And now that the things are stable, I will deepen the chamber and put in my lens. This is a single piece lens, which is preferable because the haptics will be softer, and I will keep the haptics away from the direction of the break of the rhexis. And well, I've succeeded. This has worked, but you need to be cautious and take all the precautions that we spoke about in order to weigh your decision. Your experience with these surgeries should matter. How you've done in the past should matter in taking a decision whether to convert or whether to go ahead and do a phaco in a hard cataract with a broken rhexis.
Thank you very much.